Hello everyone. So welcome to the next session on infectious diseases. So in this session we are going to discuss some of the very important viral diseases. Okay, fine. So before going into the topic proper, let us give you an overview of what are the various viral diseases, okay, that we encounter. So I am broadly dividing them into respiratory, digestive, systemic with skin eruptions, hematological disorders, arboviral hemorrhagic fevers, skin genital warts, central nervous system. So, in respiratory system, you already know adenovirus, rhinovirus, influenza virus, respiratory syncytial virus. They are going to mainly cause upper and lower respiratory tract infections. Fine. And respiratory syncytial virus is known to cause croup. Okay, what is croup? Laryngotracheobronchitis. And digestive system, we have mumps, rota, noro, hepatitis A, B, C, D and E. Fine. Out of that, B and C mainly cause chronic hepatitis. B and C mainly cause chronic hepatitis, whereas hepatitis A and E causes acute viral hepatitis. A point, hepatitis E virus will cause fulminant hepatitis. Okay, will cause fulminant hepatitis, especially in pregnancy. Fulminant hepatitis in pregnancy. Then measles, rubella, varicella, herpes simplex 1 and 2. All these are mainly known to cause, that is skin manifestations. Measles, German measles or rubella, shingles, chickenpox, herpes, genital herpes. Remember, genital herpes is mainly by herpes simplex 2. Then hematological disorders, we have cytomegalovirus, Epstein-Barr. Epstein-Barr is known to cause infectious mononucleosis. We will discuss cytomegalovirus and virus and Epstein-Barr virus in detail in today's session. Then human immunodeficiency virus, acute immunodeficiency syndrome, that is AIDS. Then hemorrhagic fever, dengue virus, we have 4 serotype, 1, 2, 3 and 4. They are known to cause dengue hemorrhagic fever. Then yellow fever virus causes yellow fever. Then genital warts is caused by human papilloma. Human papilloma virus, I have already discussed in neoplasia that human papilloma virus have 2 low risk, that is HPV. Okay, I am writing here just for your knowledge. HPV 611. They are low risk HPV. They are mainly causing benign lesions, that is warts. Whereas 16, 18, which are high risk, 16, 18 are high risk. They are mainly going to cause cervical carcinoma, then anogenital carcinoma, and next one is head and neck cancer. Fine, okay. Then we have poliomyelitis. Of course, polio has been eradicated, so there is no point in discussing it further. JC virus, progressive multifocal leukoencephalopathy. So the first important virus that I am going to discuss is about measles. I am just going to see the very salient features that you should remember. Number 1, it is causing an acute viral infection. And remember, it affects multiple organs. So it has severe, mild to moderate or severe systemic manifestations. Fine, yes. And remember, measles, they are mainly affecting which group? Age group? Children. Of course, you know that. Then measles can produce severe disease in people with a defect in immunity, that is immunocompromised states like HIV or hematological malignancy. Fine, yes, okay. And you already know that how you can diagnose the measles by the serology or detection of viral RNA in respiratory secretions or urine. Measles is an RNA virus. Coming into the pathogenesis, yes, here only we are going to focus a bit. Okay, what is the pathogenesis? Okay, fine. So remember, the measles, which is a single-stranded RNA virus, it belongs to the Paramyxoviridae family. Okay, Paramyxoviridae family. Okay, which includes mumps, respiratory syncytial virus, para-influenza virus. Para-influenza virus, respiratory syncytial virus are known to cause CROP. Okay, and human metapneumovirus. All these are members of Paramyxoviridae family. Okay, now coming into the mode of spread. The mode of spread is via airborne or aerosolized, that is via aerosols. Fine. Yes. Remember, COVID-19 has not been known to spread through aerosols. Fine. Yes. So how it is going to what is the pathogenesis? Yes, that is the next important thing we have to remember. So remember, this measles has been known to activate a protein called the SLAM F1. What is SLAM F1? I am going to highlight it with a different color. Signaling lymphocytic activation molecule family member 1, which is expressed on activated lymphocyte dendritic cell monocytes, and this is the initial receptor for viral infection. You will get an MCQ. SLAM F1 is an what? Initial, or it's like a pattern recognition receptor. Fine. Yes. Then we have something called the nectin-4, which is found on the basal surface of epithelial cell. This is responsible for replication of the virus. Just all these are one MCQ question. Yes. Then comes the straight away MCQ question. What is the cell surface receptor for measles virus? There you are going to write CD46. CD46. Okay. Actually, the CD46 and this has been used. Okay. What to say, mainly by the vaccine virus. Okay, vaccine virus, no, we are getting measles rubella vaccine. So this vaccine virus is going to attach to the CD46 receptor, not the wild type of virus. Fine. Then what it is going to, where it is going to replicate? In epithelial cells and leukocytes. Initially, I told you the mode of what spread is via the respiratory tract. So it is going to multiply within the respiratory tract. Then it spreads with the local lymphoid tissue, causing viremia. Then dissemination to conjunctiva, okay, skin, respiratory tract, small blood vessel, lymphatic system, and CNS. Fine. So okay, that's the important thing. Then remember, measles will produce some characteristic rashes. I'm not going to detail about what are the rashes, and all this you can read from microbiology. Just a point at last, that is, in malnourished children, this one of the most, what are the complications of measles? If I ask you, your answer should be pneumonia, diarrhea, protein losing enteropathy, okay, keratitis, okay, that is cornea, then scarring, blindness, encephalitis, and one of the most important life-threatening fatal complication, the answer should be subacute sclerosing panencephalitis, SSPE, subacute sclerosing panencephalitis. Okay, yes, that should be your answer. Okay, fine, yes, and remember. Fine. Okay, that's it. Then coming into the morphology. Yes, this is the part you have to focus on. As far as path is concerned, okay, this is the part you have to focus on. What is the morphology? See, morphology, you are going to get blotchy reddish brown rash of measles virus on face, trunk, proximal extremities, okay, which is produced as a result of mononuclear infiltration and dilated blood vessels of the skin, okay, and we have some pathognomonic complex spots which are located in the near the opening of the stem cells just in the mucosa, oral mucosa. This is because of necrosis, neutrophilic exudate, and neovascularization, and we have some characteristic multinucleated giant cells which are seen in measles. This question has been asked thousands and thousands of times, and this is what we call as Warthin-Fingalti giant cells. Okay, because this is okay, I will show the picture. See, this is the characteristic. You should not miss this. Okay, this is the characteristic Warthin-Fingalti giant cells. These Warthin-Fingalti giant cells are nothing else but eosinophilic nuclear and cytoplasmic inclusion bodies. Viruses have always known to produce intranuclear, intracytoplasmic, and some viruses produce both intranuclear and intracytoplasmic inclusion bodies, that you can read from microbiology. Fine. So this is the most important thing you have to remember. Okay, and remember, these Warthin-Fingalti giant cells are mainly characteristically found in the bronchoalveolar lavage. Okay, from lungs we can get what we call as BAL, bronchoalveolar lavage, as well as from the sputum. Okay, yes. So these are the important points that you have to remember as far as what is concerned measles is concerned. Okay, Next, I am going to discuss about viral hemorrhagic fever. The viral hemorrhagic fever is nothing else but it's a severe life-threatening multi-system syndrome. There will be vascular damage. So actually what happens in viral hemorrhagic fever? Finally, the patient dies due to shock. Even the viral hemorrhagic fever is mainly we have dengue, we have Ebola, we have Hanta, okay, we have Marburg, Lassa. All these viruses are known to cause viral hemorrhagic fever. Okay, yes. So why? Because initially they will produce fever, headache, myalgia, rash, neutropenia, thrombocytopenia. Finally, there will be hemodynamic collapse and shock. The patient will die due to shock. Because dengue, we have mild, moderate, and finally we have dengue hemorrhagic fever, and at last we have dengue shock syndrome. So all these are the various stages of dengue. So, but remember, initially they all start with a fever, headache, myalgia, rashes, and neutropenia. Finally, there will be thrombocytopenia, which will lead to severe life-threatening diseases, and which will lead to hemodynamic deterioration inflammation, and finally they will die due to shock. So there will be Ebola, Marburg, Lassa. Okay, fine. And remember, dengue you can read from microbiology, because no textbook other than microbiology will explain much more dengue in detail. Just read from that. Just remember some of the characteristic points. Okay, whenever a patient comes with a fever, okay, I'm going to write here some of the characteristic features of dengue. Okay, I'm going to write here dengue. Okay, dengue means there will be fever of less than 7 days duration. History. Okay, in order to solve case scenario based question, less than 7 days duration, there will be retroorbital pain, then myalgia, purpura. Okay, purpura. All these are features which, these are the hints, so that you can diagnose it as a dengue. Okay, it as a dengue. Okay, retroorbital pain, myalgia, purpura. Okay, and okay, purpura. They may not give thrombocytopenia. Okay, usually in history we don't use the word like thrombocytopenia and that. Okay, they will give, but suppose on lab any parameters. Okay, thrombocytopenia, that too less than some 1 lakh they will give. Okay, 1 lakh or 50,000 per cubic millimeter. Okay, they may give this. So just remember all these points. Okay, these are these characteristics. Please always search for the words like retroorbital pain, myalgia. Okay, then thrombocytopenia. So these are the words which helps you diagnose that it is dengue. Fine. Yes. Actually, what is the basic pathogenesis behind this viral hemorrhagic fever? Damage to blood vessel, which may be either a direct damage or because of some inflammatory cytokines. The most important of which what we have been discussing is about Ebola. You know, Ebola outbreak we have from 2019. Okay. Yes, and remember, it has some specific mechanism. This Ebola virus has some specific mechanism to protect, which can evade the immune response. Two viral proteins are there. One is VP24 and VP35. It will inhibit the action of type 1 interferons. See, interferons, we have alpha, beta, and gamma interferons. Out of this, these interferons are mainly having what? Antiviral action. So these have two proteins called as VP24, and another one is what we call it as VP35, which will inhibit the action of type 1 interferon. Okay, and this VP24 will block type 1 interferon signaling by preventing the dimerization of STAT1. STAT1 is a transcription protein factor. Okay, yes. Okay, then so morphology, nothing else. You will have platelet dysfunction, endothelial injury. That is the features of shock. That is what you are going to write. Yes, the next very important virus that we are going to discuss is what we call as Sika virus. Sika virus is belonging to flavivirus. We have recent cases in Kerala. In Kerala, we have recent cases reported. Okay, a pregnant lady has developed Zika virus. Okay, yes. So it is mainly transmitted by Aedes mosquito. Okay, that is primarily Aedes aegypti. There has been no animal reservoir. Okay, no animal reservoir for Zika has been demonstrated. But okay, then how it is transmitted by mosquito borne and perinatal transmission. Perinatal transmission is very deadly. Okay, because the baby, which is suppose if a pregnant lady got Zika virus infection and the baby born will be having microcephaly, microphthalmia, okay, developmental delays, everything. Okay, blood transfusion and sexual contact also the Zika virus can spread, but we don't evidences to support that. And it is also detected in semen, vaginal secretion, breast milk and urine for up to several months after infection, but there is no other proper and valid data to support the transmission through these means. Okay, then what are the manifestations of Zika virus are non-specific fever, myalgia, arthralgia, conjunctivitis, maculopapular rashes, which last for few days to 1 week. Okay, and remember, sometimes this infections may mimic the symptoms of GBS, Guillain-Barré syndrome. Guillain-Barré syndrome is it's a peripheral demyelinating syndrome. Okay, Guillain-Barré syndrome is a peripheral demyelinating syndrome. Okay, Guillain-Barré syndrome is a peripheral demyelinating syndrome. Fine. Okay, then next most important thing is okay, that is it's an RNA virus again. Okay, let us see about the morphology. This is where the area where we have to focus. See, as far as in pathology, whenever they ask about infectious diseases, please try to put a heading called morphology and write about the histopathological finding, because the rest of the thing, like the features of Zika virus, the structure of the Zika virus, all those things, you are reading in microbiology. So in such the topics that I am discussing, please focus on morphology. Okay, please focus on morphology. Okay, yes. Okay, in morphology, what you can see, I told you it is mainly going to have some CNS manifestation. So there will be cerebral calcification, cerebral atrophy, then Next is what we call it as ventricular enlargements. Okay, ventricular enlargements, hypoplastic cerebral structures were the most common adverse outcomes with the Zika virus infections. Okay, fine. I told you, microcephaly. Okay, small for gestational age. All these are some of the important. Okay, some of the important things you have to remember. Then ocular abnormalities like chorioretinal atrophy, optic nerve abnormalities are also common. Just remember these points. Fine. Yes. Then I told you microcephaly, ventriculomegaly, then pulmonary hypoplasia. Okay. The neuronal depletion with microcalcification and microglial nodules. All these are the points that you have to remember in case of Zika viral infection. See, this is a morphology of a brain from a 2-month-old child. You can see. What to say, yes, see what the blue color, the basophilic structure. Okay, these are these basophilic structures, what you are seeing, these basophilic structures, they are calcification. Calcium stains like basophilic in normal H&E staining. Okay, and you can see these are the cortex with the degenerating neurons. Okay, these are the cortex with the degenerating neurons. Fine, just remember this. Okay, so with this we have finished what all virus, we have finished measles, we have finished viral hemorrhagic Zika virus, then dengue. Please, I am requesting, please read very detailed, in depth. You should read from dengue, one case scenario must. Okay, dengue, malaria, TB, these are the 3 important areas you have to focus on because these diseases are very common. Then coming into herpes virus infection. So I'm not going to about what are the various clauses, alpha, beta group, gamma group, all those I'm not going to, because that you will read from a micro. As far as path is concerned, let us focus on herpes simplex virus 1 and herpes simplex virus 2. Both differ serologically. See, only they are differing serologically, but genetically and all, and the type of infections they are causing, almost they are similar. Fine, yes. And remember, the viruses spread to sensory neurons, and there only the neurons only these viruses are undergoing replication. Fine, yes. Next is, yes, what is LAT? See, this herpes group of viruses are known for latency. That means after infecting, they will remain dormant within the neurons, and they get reactivated when there is conditions like immunosuppression. So that is during latency, they will secrete some proteins called as latency associated viral RNA transcript. Okay, yes, and they may contribute to latency by conferring resistance to apoptosis. They will silence the lytic gene expression, all those, and this reactivation may occur especially in cases of immunosuppression. When the patient is immunosuppressed, this virus will undergo reactivation. Okay, yes. Okay, once this is done, next is, yes, herpes simplex viruses. It may causes corneal epithelial disease due to direct viral damage, corneal stromal disease. Then even it may causes herpes encephalitis. Okay, remember, just a single MCQ you are going to get. Rest everything please read from microbiology. Okay, because it's not properly given in Robbins. Okay, you can just refer your microbiology textbook. Okay, you can refer your microbiology textbook for the further updates. Fine, yes. And remember, there is an inherited mutations in toll-like receptor 3 has been associated with increased risk of HSV encephalitis. Okay, this is a potential MCQ question. So that's the only point that I want to discuss you there. Yes, coming into the morphology. See, the herpes simplex virus produces some characteristic pink to purple intranuclear inclusions called as Cowdrey type A inclusion bodies. In order to know much more about intranuclear inclusions and intracytoplasmic inclusion, you can take the chapter General Virology in any of the microbiology textbook like Apurva Shastri. It's well in depth mentioned there. Okay, yes, fine. So it also produces inclusion bearing multinucleated syncytia. Fine. Then what about the clinical manifestation? Mainly, it may start with fever, blisters or cold sores around the mucosal orifices, intraepithelial vesicles, then intracellular edema, ballooning degeneration of the epidermal cells, the burst and crust, all those things. I will show you a picture. So this is one of the skin lesions of chickenpox, not herpes simplex. It is the varicella zoster. You can see the big intraepithelial vesicles. Okay, you can see the big intraepithelial vesicles. Fine. And even gingivostomatitis, that is mainly caused by HSV1. I told you genital herpes is mainly caused by HSV2. There will be superficial ulcerations. Okay, there will be superficial ulcerations. Okay, And HSV1, there will be vesicular eruption, there will be cervical lymphadenopathy, then herpetic vitiligo. This is a characteristic feature you have to remember. Herpetic vitiligo, they are nothing else but swollen and painful erythematous lesions which are seen in the phalanges, fingers and palm. Okay, yes. Once see, this is the picture, you can see some glossy, okay, you can see the glossy intranuclear, okay, these are the glossy intranuclear viral inclusion bodies. Okay. Then next most important thing, what are the corneal lesions? See, corneal lesions are very, very important. You must mention about this. That is herpes epithelial keratitis and stromal keratitis. You know, cornea has different layers: endothelium, epithelium, stroma. Out of that, when the epithelium is infected, that is the superficial epithelium is infected, it causes herpes epithelial keratitis, and stromal keratitis because of infiltrates of mononuclear cells leading to neovascularization. There will be scarring and opacification of cornea, and finally, it may cause even blindness. Then I told you herpes simplex encephalitis, it is associated with increased risk in inherited mutations of toll-like receptor 3. Fine? Yes. Then herpes esophagitis, bronchopneumonia and herpes hepatitis may also cause liver failure also. Fine? Just remember about Cowdrey type A inclusion body, herpetic vitiligo, fever blisters. Then genital herpes is caused by HSV. What is that? HSV2. Fine? Yes. Okay. Once this is done, let us discuss about varicella zoster virus. This is going to cause what we call as herpes zoster or shingles. Okay. This is going to cause chickenpox and reactivation of the latent. I told you this herpes group, herpes, varicella, all are known to cause latency. So they will remain dormant within the dorsal root ganglion. Okay, and once they undergo reactivation, what it is going to happen? It is going to cause shingles. Shingles is nothing else but herpes zoster. Okay, that is reactivated varicella zoster virus. Fine. Yes. Then another most important point, see I told you, they get like in the dorsal root ganglion or the satellite cells which are present around the neurons. Fine? Yes. Then, okay. Next, what else? Morphology. Coming to morphology. Fine. The chickenpox, approximately 2 weeks after respiratory infection. Fine, the rashes will appear. On histological examination, that is what we have to do. There will be intraepithelial vesicles with the intranuclear inclusions. I have already shown the picture. Okay, I have already shown the picture. Fine, yes. Shingles occurs when varicella zoster virus has long remained in the dorsal root ganglion and they are reactivated because of immunosuppression, and they may cause what intense itching, burning or sharp pain. Okay, and remember trigeminal nerves are involved. When suppose in reactivated herpes zoster virus infection, there will be facial paralysis, that is what we call as Ramsay-Hunt syndrome, and there are also intranuclear inclusion bodies like in case of herpes simplex virus. And similar to HSV, whenever there is mutation in toll-like receptor 3, there is increased risk of varicella zoster virus encephalitis. Okay, so this is the herpes zoster virus within the dorsal root ganglion, and you can see the ganglion. See, this is the ganglion undergoing necrosis and inflammation, and you can see some intranuclear inclusions also like herpes simplex virus. Okay. Next most important viral infection that what we have to know is what we call it as Cytomegalovirus. It is a member of beta group of herpes virus. Okay, it is a member of beta group of herpes virus. Okay, yes. It's a member of beta group of herpes virus. Fine. And remember, the Cytomegalovirus has a special predilection for those who have undergone transplantation, bone marrow transplant, renal transplant, liver transplant. So in transplantation, one of the most common cause of infection, if someone asks you, your answer should be Cytomegalovirus. Fine. Yes, it is going to mainly infect the monocytes. Okay, it is going to mainly infect the monocyte. Okay, yes. And this, we have something called as infectious mononucleosis. Okay, infectious mononucleosis. Infectious mononucleosis is actually caused by Epstein-Barr virus. But even viruses like Cytomegalovirus are known to cause mononucleosis-like infection. You can refer in Apurva Shastri, a very beautiful table is given. What is the difference between infectious mononucleosis and mononucleosis-like infection? Fine? Yes. And remember, the cytomegalo infect, why it is, see the name itself, cytomegalo. So the virus, once after infecting the cell, what will happen? The entire cell will become gigantic. So you can see here, okay, gigantic, and which typically contain a large inclusion surrounding by here halo. So this will be an inclusion, and there will be an empty space, this which looks like owl eye. So owl eye inclusion bodies, we have lot of owl eye. Okay, owl eye we can see in rheumatic heart disease, in rheumatic nodule, Ashkoff nodules, we can see owl eye. We can see Reed-Steinberg cells in Hodgkin's lymphoma, we have owl eye. Again, the third one is cytomegalovirus, we have owl eye inclusions. Fine. Then this cytomegalovirus transmission can occur 1, 2, 3, 4, 5. 5 methods. 5 ways. Number 1 is transplacental, through the placenta. So in baby, if we have IgM antibody, only IgG will cross the placenta. Suppose if on serology, if we get IgM positive in baby, it indicates that it may be cytomegalovirus infection. Then neonatal transmission via birth canal or through breast milk, then via saliva, through genital route, okay, and iatrogenic transmission via organ transplant or blood transfusion. Fine. Now let us see the pathogenesis. Fine, pathogens. I told this cytomegalovirus is mainly going to infect in immunosuppressed patients like bone transplant, okay, renal transplant, all those things. Okay, how it is going to act? It is mainly going to down modulate the class 1 and class 2 MHC molecule, okay, and this can also evade NK cells by producing some ligands which will block the activating receptors and activate the inhibiting receptors. That means NK cells, you can go back and revise your knowledge, refresh, okay, your knowledge in NK cells. Okay, in NK cells we have two types of receptor, activating receptors and the inhibiting receptor. Normally it is the activating receptors which will be activated so that NK cells can kill the antiforeign antigen, whereas the cytomegalovirus will form some protein which will inhibit the activating receptors and promote the inhibiting receptor, so NK cell cannot kill the cytomegalovirus. Fine? Yes. Okay. Then infected cells, I told you there are prominent intranuclear basophilic inclusions, okay, and there will be a clear halo surrounding it. This is what we call as the characteristic owl eye appearance, and the infected cells are enlarged, they are gigantic, okay, and they show some cellular antinuclear pleomorphism, okay, even glandular organs, neurons, alveolar macrophages, epithelial cells, endothelial cells of lungs, kidney, okay, and all this may causes focal necrosis of these organs. Fine? Yes. Then, okay, congenital infections. Congenital infection is, suppose if the mother is pregnant and suppose and after delivery the baby got cytomegalovirus, mainly you can see microcephaly. Okay, mainly you can see cytomegalovirus, microcephaly, and cytomegalovirus is known to cause CMV retinitis. What is that? CMV retinitis. CMV retinitis in HIV people. Okay, in HIV patients. Cytomegalovirus retinitis. And remember, diagnosis is made by PCR or viral DNA detection. Then perinatal infection, I have already told you. Then please read about what is mononucleosis like illness. There will be fever, atypical lymphocytosis, lymphadenopathy, hepatitis, marked by hepatomegaly and abnormal liver function test. Okay, yes. And remember, the most common, so this infectious mononucleosis like illness is the most common manifestation of cytomegalovirus in competent host, not compromised, immunocompetent host. For example, I am immunocompetent. Suppose if I get cytomegalovirus infection, I am not going to get any owl eye appearance, I am not going to get CMV retinitis or nothing. I am going to get like infectious mononucleosis like illness. Please go to my Apurva Shastri, take Apurva Shastri. There is a very beautiful table which shows the differentiation between infectious mononucleosis and mononucleosis like illness. In immunosuppressed patients, I have already told you what there will be pneumonitis, okay, pneumonitis and colitis. Pneumonitis is one of this has been asked as an MCQ. Pneumonitis is one of the most common manifestation in immunocompromised patients. Okay. And next, what we are going to discuss is EBV, Epstein-Barr Virus, okay, whose pathology, everything is going to, has to be discussed a bit in detail. Fine. So this Epstein-Barr virus, it causes infectious mononucleosis. Whereas infectious mononucleosis like illness is caused by cytomegalovirus. This causes infectious mononucleosis, which is a benign lymphoproliferative disorder, and it is also going to cause some other lymphomas like Burkitt's lymphoma, nasopharyngeal carcinoma. So what is the symptoms? Fever, sore throat, generalized lymphadenopathy, splenomegaly, and in blood we can see some atypically activated T lymphocyte. These atypically activated T lymphocytes are also called as Downey cells. Don't worry, I will discuss that, explain that very soon. Fine. So, and what are some of the complications? Some of the complications are hepatitis, meningoencephalitis, and pneumonitis. Fine. And remember, this mainly affects people of upper socioeconomic class. Okay, I don't know the reason. Fine. Epstein-Barr virus is transmitted by, EBV, infectious mononucleosis, is also called as Kissing's disease. Kissing disease. It is also called as glandular fever. Okay. Why kissing? Because through saliva you will get this. Through saliva you will get this. Fine? Yes. So the source of this virus is the B cells which are present in the oropharyngeal epithelial cells. Fine? Yes. Okay. So what happens? What happens? Fine. So how they found that? Because in X-linked A gamma globulinemia there won't be any B cells. So in B cells there won't be any B cells. So this in patients who are having X-linked A gamma globulinemia, that is also called as Bruton's disease. So in Bruton's disease there won't be B cells. So since there is no B cells, they won't get infection with the Epstein-Barr virus, and that is how they found that the B cells are the primary reservoir. Okay, this is a very, very important question. I'm going to write it. B cells are the primary reservoir. B cells are the primary reservoir of Epstein-Barr virus. So how it is going to bind? See, this is going to bind with the glycoprotein CD21, also called CR2, okay, which is the receptor for C3D of the complement pathway, which is present on the B cell. Just remember, it binds with the CD21 or CR2. Finish. Okay, it's an MCQ. They may ask you, okay, what is the receptor for CD21 or CR2? What is the receptor for measles? It is CD46. CD21 for Epstein-Barr virus. Okay. So what will happen? This B cells will undergo get infected. This will lead to viral replication, and finally the cell will undergo lysis. The virions will be released. Fine. Okay. And what happens? Yeah, then this virus, I told you herpes group of virus all have a feature of latency. So the B cells that are latently infected with Epstein-Barr virus, they will be activated, they begin to proliferate, they begin to disseminate, and there will be polyclonal expansion of the Epstein-Barr virus infected B cells. Okay, that means what? Uncontrolled proliferation of B cells. That is the meaning. Okay, yes, and these uncontrolled polyclonal expansion of B cells can be detected by what we call as heterophil antibodies. We have a lot of heterophil agglutination test. Okay, we have Weil-Felix reaction, so and so. So similarly, Paul Bunnell test. Am I right? Yes. So all those these heterophil antibodies we can use to diagnose Epstein-Barr virus. It may also causes immune-mediated thrombocytopenia, because this Epstein-Barr virus may infect the platelets. Fine. Yes. Then why? And so I told you that we will get atypical T lymphocytes. See, the B lymphocytes are only getting infected. Then how comes the T lymphocytes become atypical? Let us see. You know that the most important component of the cell-mediated response are CD8 plus cytotoxic T lymphocytes and the NK cell. Okay, am I right? Yes. So, because of the polyclonal B cell expansion, cell-mediated immunity and humoral immunity are very closely related. They have to work together. So because of the polyclonal expansion of the B lymphocytes, there will be unnecessary stimulation of the T lymphocytes. Okay, there is unnecessary stimulation of the T lymphocyte. What T lymphocyte? Cytotoxic CD8 plus T lymphocyte. They may ask in MCQ. CD8 plus T lymphocyte, not CD4 plus. And because of this unnecessary stimulation or activation of the cytotoxic T lymphocyte along with the NK cell, but mainly cytotoxic T lymphocyte, these cells will undergo proliferation, and that is what we call it as atypical lymphocytes. That is also called as Downey cells. Okay, atypical T lymphocytes, they are also called as Downey. Okay, Downey cells. Okay, and the characteristic appearance. Okay, the characteristic appearance of these Downey cells. Okay, this is what we call it as the famous ballerina skirt appearance. Don't worry, I will discuss again infectious mononucleosis in hematology. Ballerina skirt appearance. Okay, ballerina skirt appearance. That means it looks like a skirt of ballet dancer. Fine? Okay. Fine. And I told you to make us Burkitt's lymphoma, 814 translocation, MYC, oncogene, all these things already I have discussed in neoplasia. Fine. Coming into the, yes, morphology. What are the areas? Blood, lymph nodes, spleen, liver, CNS. Peripheral blood shows absolute lymphocytosis. More than 60% of WBC will be lymphocyte. Usually 50 to 60% only will be lymphocyte. Here more than 60%. And out of that, around 80% will be large atypical lymphocyte which has abundant cytoplasm having vacuolations, indented nucleus and acidophilic granules. They are called as CD8 plus. They are nothing else but CD8 plus cytotoxic T lymphocytes. They are atypical lymphocytes, also called as Downey cells, having the characteristic ballerina skirt appearance. Then we have the lymph nodes which will be discrete and enlarged. Mainly the patient will have cervical and axillary and as well as inguinal lymphadenopathies. On histological examination, the most striking feature is the expansion of paracortical areas. You know, in lymph node we have cortex, medulla and paracortex. In cortex and medulla we have the B follicles, B lymphocyte. There is a paracortex, have the T lymphocyte. So since there is abnormal proliferation or unnecessary stimulation of the T lymphocyte which are present in the paracortex region will undergo expansion. That is what I have mentioned here. Fine. This Epstein-Barr virus have some nuclear antigen which is called as latent membrane protein 1 and another one is called as EBNA2. That is Epstein-Barr virus nuclear antigen 2 and LMP1, that is latent membrane protein. Okay, this genes can be detected in PCR. It may also cause and this remember fine. Yes, next spleen. The spleen will be also enlarged. Okay, there will be expansion of white pulps and red pulp sinusoids. Why? Because in white pulp we have the T lymphocyte. Yes, of course, the red pulp is also expanded and enlarged. Then liver shows hepatomegaly and there will be atypical lymphocytes in the portal area and sinusoids. Fine, but there is no specific features in the liver children. Okay, see, this is you can see the characteristic picture. Okay, you can see the characteristic pictures. See, there is some abnormality like a thickening, a bluish thickening you can see. So this is the atypical lymphocytes. So this is how the lymphocytes will look. Okay, this is how lymphocytes will look. This is called as the atypical lymphocytes, also called as Downey cells, having the characteristic ballerina skirt appearance. Fine, yes. Then clinical features, I have already told you, that is infectious mononucleosis like features, not infectious mononucleosis like infectious mononucleosis. Fever, sore throat, lymphadenitis, malaise, fever. Okay, then we have what we call it as lymphadenopathy. Yes, lymphadenopathy. Then fatigue. Yes. And even we may think that the patient is having leukemia or lymphoma. Okay, the symptoms will be almost like that. And the diagnosis, okay, you may get hepatitis, I have already told you. Then febrile rash, there will be lymphocytosis. More than 60% of the WBC will be lymphocyte, atypical lymphocyte. Heterophil antibody test will be positive. Then EBV, EBNA, capsid antigen, then LMP1 antigen, all those will be positive. Fine, yes. Then there will be hepatic dysfunction with elevated liver enzymes. Okay, yes, bone marrow dysfunction, spleen enlargement. Okay, then I told you polyclonal B cell proliferation. So there may be a chance of converting, okay, there will be a higher chance of developing monoclonal B cell lymphoma. And a serious consequence of EBV, this is a very important MCQ, VVIP MCQ, what is X-linked lymphoproliferative disease? This is nothing else but called as Duncan's disease. Duncan's disease also called as X-linked Duncan's disease also called as X-linked lymphoproliferative disease is caused by mutation in SH2D1A. SH2D1A gene. Okay, yes. And actually this gene encodes for a protein which mainly helps in T cell and the NK cell activation and antibody production. Okay, yes. So these are the important thing. Epstein-Barr virus already, you know, the pathogenesis, a beautiful flowchart has been given, a pictorial representation has been given in chapter of neoplasia. Okay, just 1 second. Let me see that. Yeah, I think in this only. Microbial carcinogenesis, right? See, in microbial carcinogenesis we have EBV. See, Epstein-Barr virus induced Burkitt's lymphoma, CD21. See, CD21 increased MYC protein, 814 translocation. You can copy this picture also here. Okay, very beautifully they have mentioned LMP1. Okay, which behaves like a constantly. CD40 is the receptor. Very, very important. CD46 is for what we call it as our measles. CD40 is the receptor, and this LMP1 is going to activate nuclear factor kappa B and JAK-STAT signaling pathway that is responsible for the B cell activation, and that is responsible for the formation of Burkitt's lymphoma. Okay, you can refer this picture also. Okay, yes, fine. So I think with this we have finished the viral diseases in the module infectious diseases. Thank you.